Good day, everyone, and welcome to today's program. All participants are in a listen-only mode. You may submit questions in the Q&A pod to the bottom right of your presentation. Please note that this call is being recorded. It's now my pleasure to turn the conference over to Tamitha Thomas-Hassey. Please go ahead.
Great. Well, thank you so much, Destiny. Greetings to each of you, and welcome again to today's webinar. My name is Tamitha Thomas-Hassey, and it is my pleasure to moderate today's session, in which we are going to highlight 4 practices, promising practices for ensuring that Medicaid members know about, seek out, and use covered cessation treatments, and together with our colleagues discuss specific strategies to address challenges faced when working with state Medicaid agency partners to promote covered cessation treatments. So to provide us with an official welcome and to set the stage for the session today, I'd like to introduce all of you to Anne DiGiulio. Anne is the Manager of Lung Health Policy at the American Lung Association, where she heads up their Tobacco Cessation Policy Project, which includes managing 2 federal grants related to the Lung Association's tobacco cessation work, and is also responsible for technical assistance to the field, to all of us on tobacco cessation issues, including developing resources and fact sheets. So Anne, I am pleased to turn the webinar over to you at this point.
Thanks, Tamitha, and thank you to everyone for joining us today. I'm just going to get us started by setting the stage about tobacco cessation, kind of where we are in the coverage landscape. As you probably all know, the Affordable Care Act was passed in 2010, and there's a couple of different provisions in the Affordable Care Act related to tobacco cessation. First, all pregnant women on Medicaid are required to have access to all 7 FDA-approved tobacco cessation medications, and then all 3 forms of counseling. Additionally, there's a provision about for traditional people enrolled in traditional Medicaid. Those individuals are required to have access to all 7 FDA-approved medications. And then for those states who have expanded Medicaid, there's the tobacco cessation benefit is part of the USPSTF, or United States Preventive Services Task Force's preventive services. And that means that those individuals are required to have access to all 7 FDA-approved medications and all 3 forms of counseling with no cost sharing and no prior authorization. So as you can see, there's a lot of diversity and a lot of differences in the types of requirements, but there's still a lot of coverage that's supposed to be there. We know that coverage varies. Despite all these requirements, coverage still varies between states and then also within states because of the different Medicaid managed care plans and just other general variations that the states have. The other thing we also know is that tobacco cessation utilization in Medicaid is very low. There was a study that came out back in January that showed that less than 10% of Medicaid enrollees received and used tobacco cessation medication in 2013. And so there's a big gap in what is covered and then what is actually being used, or at least what's supposed to be covered and what's actually being used. So we're kind of today working on why is there this gap and what can we do to fill in the gap. And so we worked on we found out some promising practices and lessons learned. Our report came out on June 9th, so just last week, and I believe all of you should have received it in an email. I mean, if not, you can find it on our website, and we'll send it out again after with the follow-up email to this webinar. We looked at 5 states' efforts about tobacco cessation promotion. And those states are California, Massachusetts, Mississippi, Vermont, and Wisconsin. And 4 different trends emerged, as well as some other lessons learned. But I'm going to kind of highlight these main 4 trends and then turn it back over to Tamitha for a discussion. And we looked at both promotion to enrollees and their families, and then also promotion to providers, so they know what's covered. But some of the promising practices and the lessons we learned were to understand the Medicaid coverage landscape first, so to know what's covered, how many people on Medicaid smoke, maybe what plans those people are in, to build and sustain close relationships with key allies and state Medicaid agencies. So figure out who you need to talk to get the work done. And then also the next one, don't forget partnerships at an organizational level, the leadership level. That's also been crucially important for some of these states. And then last, to develop a plan for evaluation, to make sure what you're doing works and to see if there's any ways to improve it for the future. So with that, I'm going to turn the conversation back over to Tamitha to introduce our speakers.
Wonderful. Thanks so much, Anne. So now we're going to hear from three of your colleagues who, as Anne said, have their experiences and their guidance and their wisdom reflected throughout the Promising Practices document. And so at this point, I'd like to introduce you to Anna Landau, Vicki Tucker, and Amy Winter, who are joining us. So Anna Landau is the Director of Tobacco Cessation Programs for the Massachusetts Department of Public Health in their Bureau of Community Health and Prevention. Vicki Tucker joins us as the Special Projects Officer working on statewide cessation services for the Mississippi Office of Tobacco Control. And Amy Winter is the Director of the Mississippi Office of Tobacco Control. So welcome to each of you. And I wanted to start with a question first for Anna. So as you know, with this document, we didn't want to merely do a round of case studies and sort of highlight the entire soup to nuts for specific states on promotion to Medicaid. Instead, we wanted to try to elevate the most critical practices for ensuring that Medicaid members know about, seek out, and use covered benefits. And one of those most critical practices seems to be having a clear picture of the landscape within which you are trying to operate. So Anna, how do you go about assessing the landscape of Medicaid? What are, if you could maybe in your, as you run through that with us, highlight for you anyway the three most important things to understand about Medicaid in order to have success?
Sure, Tamitha. Thanks for having us on, and good afternoon to everybody on the call. I mean, so in short, you know, how we went about assessing the landscape was to write an assessment. It was a list of 12 questions that we had. 9 of them were policy-based and 3 were data-focused. And I have the list here. I can read it out to people, and then we can also send it out later after the call. And that was really, you know, I guess developing the assessment and, you know, understanding ourselves sort of within the health department, you know, what did we really want to accomplish? What was our goal? And, you know, what would we need in order to accomplish it? So we spent a lot of time first, you know, reading various government reports and looking on government websites in order to come up with our list of questions. And then, you know, as you noted earlier, that we had to find a contact in Medicaid who would be able to answer all those questions. Or if it wasn't one person, we would have to, you know, be redirected at various times to various people. So the 12 or the 9 policy questions, I think I would start there. Those were really, until we had those 9 answered, we didn't think that we knew enough to really do anything. And so I'll just run through them for people. So it was, you know, understand what the benefit is that is offered in your state. You know, what's in the pharmacy part, what's in the counseling, you know, which type of provider is allowed to bill it, you know, are there pre-authorization requests, and the number of times per year someone can use it, all, you know, all of those standard kind of health insurance related questions for any benefit. Next, you know, is that benefit standardized across all of the managed care organizations or MCOs that Medicaid has? So here in Massachusetts we have 7. I'm sure bigger states have even more MCOs at a time. But is the benefit the same? You really need to know that, because if it's not, obviously that's going to make your job a lot more complicated. What percentage of the members are in the, well actually I would start, let me back up one. What are the names of all of those managed care organizations and how many there are? So for instance, as I said, we have 7. Then what is the percentage of the members who are in those managed care organizations versus the fee-for-service part of Medicaid? And most states will have that in about an 80-20 balance, meaning 80% of members on Medicaid are in an MCO and 20% are on a fee-for-service plan. If your state did the expansion under the Affordable Care Act, then all those people who are covered under expansion, is their benefit the same as traditional Medicaid? That's your next question. That's a really important one because, again, if they're different, then that makes your promotion job more difficult. What sort of data do either the managed care organizations or the Medicaid office itself collect about smokers, and how do they collect it? Does Medicaid place any requirements on their contracted managed care organizations about collecting data? Should they? Does Medicaid have any requirements for those same contracted MCOs about promotions to their members and about member education? Or is that sort of always at the discretion of the MCO itself? And again, the same question about providers. Does Medicaid put any requirements on those MCOs about letting them let providers know exactly what a benefit is, and do they do it in plain language, or do they do it in sort of regulatory jargon letters? So those were the policy questions that we started with, that we felt like we really needed to know before we did anything. And then the last three that were data-focused were, and you can get this if your state chooses to ask these through its BRFIS survey. You can find out, what is the current prevalence of smoking among Medicaid members? What is their current awareness that there is a Medicaid benefit? Yes, no. Do they know that there's a benefit? What is the current rate of utilization of that benefit? Like Ann just said in the intro, are only 10% of people using the benefit or more? And finally, do you know what Medicaid's priorities are, this year and for the next maybe 2 years? Their priorities in terms of data and their priorities in terms of policy, because that will tell you, a lot about what they might be interested in working on with you. So I know that's not three things, but they're all really important to get before you do anything. And am I out of time, Tamitha? Should I stop there?
Yes, instead of 3, we have 12, but I think what the audience will appreciate is that two things. One is that you're going to send the list of those 12 to them, which I think will be extremely happy, and two, that one of the first questions can be answered by easily visiting the Lung Association Cessation coverage page on their website to help learn more about the specific coverage in their state.
Yep.
Say a little bit more, Anna, if you will, about what are Medicaid's priorities. So as you were starting this process, what did you learn about your Medicaid agency's priorities around policy and data?
Sure. So it happens that probably many states are doing this, but the Massachusetts Medicaid is in the process of switching almost all of its members over into an accountable care organization framework, and that's already happened in a lot of commercial plans. So Medicaid's a little bit later with that, and so. But in doing that, that is an enormous undertaking for them. They have to write all sorts of new requirements for how contracts work with providers, and they have to come up with, quality measures of essentially what a provider would be kind of graded on or evaluated on in order to receive their payment, so that instead of the way it once was done where it was purely the number of services that were delivered, now the Medicaid will pay for quality from the provider. And so, but of course, they have to demonstrate to the provider in advance how they will measure that quality. So Medicaid has been very, very busy here anyway, writing out, all of those new rules for how they'll contract and pay providers. And so, in the case of tobacco, then the most obvious thing is that you want to make sure that tobacco is one of, or even several of, the measures that on which a provider is paid. So that was, and for us, that's been, it's taken them 2, maybe even 3 years to fully make this regulatory change, because it requires, approval federally and et cetera. So that's really all they want to do, is work on this change. And so we did make sure that tobacco was in it and will be, part of the payment structure.
Well, thank you, Anna. I heard assessment and using the information from the assessment to work to align agendas so that of the tobacco program lines up with the policy priorities of Medicaid. So thank you. Good. So this next question is for Amy and Vicki. In my conversations with you, I learned a great deal about the value of collaboration and partnership, and that this was a critical step for you in your assessment of the landscape. Can you talk with us a little bit about Mississippi's partnership with your Medicaid agency? And as you are talking about that, if you can be specific about who you're working most closely with. For example, Anna mentioned the need for utilization data. Where do I begin? Who is the person in Medicaid responsible for that? What titles should I be looking for, or what departments are important? So I'll turn it over to you. Thanks.
Hi, Tamitha. This is Vicki, and I'll start and address how we collaborate and partner with Medicaid, and then Amy will have a little bit more detail on utilization data.
Perfect.
So back in 2012, well, let me start by saying that there's a legislative mandated council to work with this office to focus on tobacco issues. That council, based on the landscape and everything that's going on in Mississippi around Medicaid participants and their smoking rate or their tobacco utilization rate, that there was definitely a need to address tobacco use among Medicaid participants. So as a part of that Tobacco Control Advisory Council, a subcommittee was formed. And this subcommittee did research and looked at manuscripts and papers and pulled data from not only Mississippi but surrounding states who had been successful in working with Medicaid. And so we took that information and proposed a plan for Mississippi. And I will say that our list was probably more of a wish list than, anything else, a proposal. But we included everything that we knew that other states had done, and we knew it was possible. So we thought that we would address Mississippi's Division of Medicaid with some of these requests. We had a meeting with Dr. Jellick, who is the director of Medicaid. He came and met with the subcommittee, and there were presentations and updates for him showing how this partnership could benefit the Division of Medicaid. He was very receptive, very interactive with the subcommittee, answered questions, and it appeared that everyone was on the same page and working towards the same mission. He even suggested some things that we could do with Medicaid that were not focused on reimbursement, but like utilization of newsletters and just partnering at every opportunity. So he was very much on board with what we were asking for. So based on those discussions and after the meeting with Dr. Jellick and several other subcommittee meetings, we drafted a proposal. This was in 2012. The proposal was submitted to the Division of Medicaid, and they responded, and basically none of the things that we had requested were granted. We got an official letter from Medicaid saying that what we will cover, and it was focused on pregnant women, and they would cover one in-person group counseling session. Then after that, they would be referred to the quit line for treatment, and they did say that they would cover NRT for pregnant women. but none of the other requests that we had asked for, like we asked for reimbursement for group counseling, reimbursement for individuals who were not necessarily physicians but trained and certified tobacco treatment specialists. So it was that type of proposal, but the only thing that was the focus of the return letter that we got was what they could do for pregnant women. So the subcommittee, basically everything kind of slowed down with the subcommittee after that, and meetings were continued to focus on Medicaid and reimbursement. So as a part of these meetings, like the regular tobacco control advisory council meetings, we also have a tobacco control network meeting. I ran into the associate director of Medicaid at another meeting, at a conference actually. There was a disparities conference, and we talked briefly about the request and everything that was in the request, and she was willing actually to be a part of helping the department move this request forward with Medicaid. So we just engaged her with all of our meetings, like the Tobacco Control Network and the advisory council meetings. She willingly participated. She would come and do presentations and updates on Medicaid to try and help us get some clarification on what was actually covered. Even though she did these presentations, we still had a lot of questions. There was a bit of, I guess, confusion about what was actually covered and what level, whether it's fee-for-service, whether it's managed care. There are two managed care providers. What's the difference in the coverage between those two providers? So we still had a lot of unanswered questions. And so she agreed to be a part of that subcommittee that was a spinoff to the advisory council. And she was going to work with that committee to develop a more refined ask for Medicaid, because actually she would see any requests that would come into Medicaid before the director would see them. After she laid her eyes on it, basically it was her decision as to whether this was something Dr. Jellick would even want to see or he would agree with. So she would send back, a request for us with feedback. And so after she agreed to actively participate, we just made sure that we invited her to all relevant tobacco meetings where we were discussing Medicaid. She has since that time worked with us to develop a one-pager. Well, she actually developed it and sent it to us, didn't work with us, but based on some of the questions that we had, a one-pager was developed. And the breakdown is fee-for-service and managed care. So we've got the one-pager. And actually, after looking at the one-pager, the one-pager lays out everything, but we still had some questions about the information and the data that were presented. So what we're doing right now is developing a list of questions for this one-pager, and we're going to let our subcommittees go over it and see if they have any additional questions. So we're going to collaborate again with Dr. Jellick's Associate Director to get clarification on this one-pager so that we can just make sure that healthcare providers and Medicaid plan participants alike are aware of what is actually available based on which level of service they get from Medicaid, just to ensure that all healthcare providers and plan participants know what the coverages are and they're able to take advantage of them. So right now, that partnership with Medicaid has grown over the years. And like I said, the associate director, she's very involved, very accessible to this office, which we appreciate very much. And she's just helping us to reshape our proposal. Everybody's trying to get on the same page so that we can come to some type of reasonable request, I guess is a good way to put it.
No kidding. And it sounds like to be able to connect using leadership, someone in a leadership position,
yes,
internal to Medicaid, almost as an informant, really, to help you reshape and reframe your request.
Yes.
Thanks,
and we've been fortunate that she's been able to do that, had she not, I'm not sure what that second proposal or that second ask might look like, but it would probably get thrown back to us again with a big no across it. But she's been very, very helpful in trying to help us get an understanding of the Medicaid language, what direction we need to go in, how we should address it, and just the specifics of the proposal. We haven't drafted the second proposal yet, or the revised one, but once we get more clarity on the one-pager that she developed for us, then meeting with her and the subcommittee again, we're hoping that we can come up with a draft of what the second proposal to Medicaid is going to look like.
That's great.
So in who you should collaborate with, someone who is as high up the chain as possible, and sometimes it's difficult to get in with that person. Dr. Young, who is the associate director, she's just very active, and she attends a lot of meetings that address disparate populations. So we've just been able to connect with her. I know meeting that person that's high up enough to actually affect change is sometimes very difficult, but in our case, we were just very fortunate. And she's very helpful, and we're hoping that this partnership continues for a long, long time.
Amy, do you want to, thanks Vicki, do you want to take us through, Amy, some utilization data?
Sure, and I'll just add to what Vicki was saying. You know, I think at the time that we made the original request, Medicaid was trying to just navigate the political landscape, and so as Anna mentioned earlier, you have to know what is important to Medicaid at that time, and so I think they were dealing with some other bigger issues, some global issues as it relates to their program, and so I think the timing, you know, was not good. But as Vicki mentioned, we have continued to develop a relationship with Medicaid, and we've built trust. And as we have done that, we've discovered some other key partners. And one of those is the Department of Pharmacy. As we invited Medicaid to our meetings and told them what we were interested in doing, we found a lot of common ground in what it was that we were trying to accomplish and what it was that they were trying to accomplish. So within the Department of Pharmacy, there's actually a drug utilization review committee, and they look at the outcomes of Medicaid beneficiaries, and they were also interested in reviewing cessation drug utilization. And as we began to share data with them about, as it was mentioned earlier, the numbers of people on Medicaid and then the lack of utilization of that cessation benefit, they became very interested as well. So we're working with them. We've got some baseline data on utilization, and then as we move forward, we can measure our progress.
Good. Thank you, Amy. So I do want to say to the audience, if as our panelists are speaking, you have a question for them, we're going to hold them to the end, but don't be afraid to type it in. I'd hate for you to be sitting on a question and you forget to what it was that you were hoping to ask. So feel free to enter that question into the Q&A log. So we can't talk about promising practices without mentioning evaluating the impact of our work. So I'm going to ask all of the panelists to address this question, and we'll start with you, Anna. How is Massachusetts evaluating or measuring the impact of promoting cessation to the Medicaid population?
Great question. And I think hopefully we're doing it a little better our second time around than we did our first time around, is what I would say. You know, I think Massachusetts did come out with a series of papers, you know, several years ago now, probably 6 or 7 years ago, about the effect that the benefit itself had on people's health and on the, you know, expenditures of the Medicaid program, but we didn't really ever have a journal article about the effect of the promotions that we did. And essentially that came down to sort of feeling like we did not have a methodologically sound enough evaluation for a journal article, you know, whereas we may have been able to write a white paper or some sort of short report, but that we felt it just wasn't strong enough to be of value to lots of other states. And, I guess sort of you can't get everything right the very first time you go out of the box. So we're hoping that we're going to do it, a little bit better the second time. I mean, I do think, and by saying that, I mean that we're intending to do another campaign, a paid campaign for our Medicaid population as well as the Medicaid contracted providers in this coming fiscal year, and we will learn from what we did last time, I guess you could say, and not, we sort of relied on the reports from the media vendor where just weren't, in our view, weren't strong enough to be able to make any kind of causal connection about actual use of the benefit versus effects. I mean, what we can say is that over these last 10 years that we've had a comprehensive benefit, we have been checking through our regular annual surveys called the BRFIS again of, do people understand that there's a benefit, how often do they use it, and that we generally get in the percentages between 60 and 70% of people who are Medicaid members do know that there is a tobacco benefit available for them. So still in all, even though we did promotion for only just a couple of years when the benefit first came out, our efforts at doing sort of earned media, or we did a paid media the first couple of years, but our efforts at earned media over the last several have been enough to kind of keep awareness high. And I guess I would say, the main question also with this is sort of finances and whether, a state has the ability to plan and put enough money aside just for an evaluation of their promotion as opposed to the evaluation of the effect of the benefit itself. And so if you do have that, the sky is the limit. You have as many, evaluators at your disposal in the health department as you, can bring along. And I guess I would say, please do it because it doesn't look like we have too much available in the evidence base right now on this. But obviously, it is important to know which elements of your promotion worked and which elements, maybe didn't work as well. Does that answer what you're thinking, Tamitha?
Yeah, no, that was great. Thanks, Anna. I appreciate that. I certainly do. And that, yeah. So, Amy and Vicki, anything to add here from your experience? Any words of wisdom to build on Anna's?
Well, I think Massachusetts is a little more, they're further down the path than we are at this point, but our evaluation would be seeing if we're having more Medicaid callers into the quit line, and then also looking at that drug utilization review to see if the medications are being used by the Medicaid beneficiaries.
So before we open it up to questions from the audience, which I see many of you chiming in, which is exciting. I'd like to talk a bit more about what has made this promotion work difficult for you. We did highlight some of the challenges in the document, but let's highlight just a few here as well as how you address them. So I'm going to stick with Amy and Vicki at this point. What has been so far the most significant unanticipated challenge faced during this work and the key strategy for addressing it?
I think the most, this is Vicki, unanticipated challenge, when I gave a brief history of meeting with the director of the Division of Medicaid and how interactive and on board and excited he was, and then once we submitted the proposal, not getting any of the things that we proposed, I think we didn't anticipate any opposition from Medicaid based on that meeting, but we came to find out that even though Medicaid, the director of Medicaid may be on board, may know the importance of cessation and promoting that among the plan participants, that he may be bound by laws or other restrictions as to where he's limited, to what he can actually negotiate with the Department of Health. I don't think we anticipated any opposition because we felt like he was open and on board to everything that we proposed and suggested.
Amy, did you want to add anything to that?
Well, just a couple things. I don't know how unanticipated these challenges are, but they were significant challenges, and one is, getting to that certain person within the Medicaid structure that can affect change and make decisions and bring these issues to the director, and it does take time. It takes time to schedule these meetings and to have these directors and different people at meetings where you can discuss the issues, and that just seems to take longer than what we had initially thought. I mean, it can take months sometimes to get a meeting rescheduled when all the parties can get there. So it's important to practice some patience. It's an opportunity for that. And then the last thing, and Anna sort of mentioned it, is the regulatory jargon, and just knowing that there is a Medicaid language and public health has a language, medical settings have a language, and so when you come together, you almost need a translator so that you can communicate, but just finding that common ground and building the relationship from there.
Anna, how about you? Any your most significant unanticipated challenge when it comes to promoting cessation to the Medicaid population?
I would say actually that the most significant unanticipated challenge was actually the data sharing. It was getting the answers to our assessment questions, and then subsequently when we did want to write certain papers that it took an extraordinarily long time, even when the parties had agreed sort of at the programmatic level, from the health department and the Medicaid side, a government-to-government agreement. We just still couldn't get our hands on the actual data. And in our case, it wasn't just months, it was years. And it sometimes exists even today. It's sort of something almost beyond the two groups of staff that work on this issue. It's hard to explain to people outside of government that it really doesn't seem like it should be that big of a challenge, but it is. And so, and I would also echo the things that Amy had just mentioned as well about having the right contacts and et cetera. That's also, but that's kind of often the case, I think, for various projects.
And back to Amy's guidance on practicing patience. Certainly,
yes.
Certainly applies here. Well, I see that we've got about 18 minutes left of our time together, so I do want to start asking questions from the Q&A log. And the first one that I'm seeing from William Branner about, for a local housing authority, do you recommend reaching out to our county or state health department to design an initiative for our public housing tenants, some of whom have Medicaid? So I want to turn it to answer that question, I would like to turn it to Erica Sword, who is with the American Lung Association. Erica, are you there?
I am, Tamitha. Thank you so much. So there have been a couple of really good questions about how to work with public housing authorities and individuals on Medicaid and to make that connection. And so first, I think it's important to point out that this really does focus on the 18 and over population. That was in part of another question. There are different FDA approvals for cessation medications only happen for people over the age of 18 and the like. And so we really want to encourage, and just to point that out, that everybody, we're just talking about adults here. So many of you are very excited to move towards working with public housing authorities, and a number of you all are already. CDC is working very closely, and I think now is a wonderful time to begin to make those partnerships and connections across the board with Medicaid staff to bring into the discussions, and also to the CDC program officers, and as well as state and local health departments. And I think any local area that has a public housing authority in it or has multi-unit housing that may want to go smoke-free, this is a good time to start to reach out and to talk a little bit about this. We are going to post a map on our lung.org/cessation coverage landing page, which is our one place that you can go to eventually get to all of our different cessation materials, and you can find out more. And also we have a lot of materials and resources available to everyone who's working on smoke-free housing, and I think between the two you'll have everything you need, and those materials are at lung.org/smoke-free-housing. And you can find the toolkits and other resources to begin to have those discussions and include your different constituencies and partnerships with that as well.
Thanks, Erica. There's also a question here, and let me read it. Since very few people quit using quit lines and or medications, is the use of the Medicaid benefit significantly different from others who access benefits through private insurance? So I offer that up to the panel if any of you want to answer that question, or certainly the team at the American Lung Association who may also have something to contribute.
Yeah, I think this is Ann DiGiulio from the American Lung Association, and unless my colleagues in Massachusetts or Mississippi want to answer it, I think I can get this one.
Sure.
So the one thing that's different about the Medicaid population that we know from the private insurance population is that the Medicaid population uses tobacco and smokes at a much higher rate, almost double that of those with private insurance. So even if the utilization rates are a little bit low, there's a greater need in this population. I was actually just on a call a couple weeks ago, and the utilization rate in private insurance is around 30%. So the 10% number is really jarring, considering that it's almost flipped, I would say, because the utilization rate of tobacco in private insurance is around 12 or 15%, I think, and I'm quoting an old MMWR, so please look that up and don't take my word for that. And then again, in Medicaid, it's about double. It's almost 30% of the tobacco use rate. So really, to get that number up, I think that's what's really jarring in some of these numbers.
I think it also, Timothy, to add one thing, the other thing is that, one of the reasons the Lung Association focuses in the MMWR coverage and important from the landscape assessment on what barriers to access there are. Barriers impact the Medicaid population much more significantly than they would individuals with employer-based care or other types of coverage, because it is that much harder for the population to navigate the insurance world. They are much more likely to have a lower education level, and the challenges that are associated with the time constraints, prior authorization, step care, et cetera, make it that much more challenging. And that's one of the reasons that the Lung Association tracks these barriers and really emphasizes them, because they really have a much more pronounced effect in the Medicaid population.
And Tim, this is Anna. Is there time for me to add one thing?
Of course.
I mean, I actually understood the question as slightly different, that this person's asking sort of, given the beliefs or the perceptions among low SES people, that we've seen in the literature about smoking and about cessation, sort of that, these medications are probably not effective, they might be addictive, they're expensive to get because, they're not covered, and sort of, I'd just be better off, trying to sort of stick it out on willpower alone. I think that does speak to something that the tobacco community overall is not quite ready or able to address yet. Insofar as, all those things that everybody just said, that, having a benefit is important and having access to medications that, have been approved by the FDA is important, but it's also true that having a much more tailored approach by the provider for someone who is low income as opposed to somebody who had higher education and higher income, it's going to take more on behalf of those providers. And so the usual interventions that we've been offering up, it's true, they don't always often work for this population, and that's why that population has this perception that it doesn't work as well for them. And I think it's something we're going to have to, work out over the next 5, 10, and 20 years. So if patients say that to a provider, that probably is their lived experience, that they have tried things and it doesn't work. And it might be because they're using them incorrectly, but it might also just be because they need a lot more than they were given in an average, clinical encounter.
And one of our participants today has the question, who were media campaigns or promotion campaigns targeted to? Was it managed care organizations or providers or patients? And so, in the document, it's clear that really the strategy is to have a campaign certainly geared toward the patients, the folks, the Medicaid members, and also the providers, a separate campaign and message and outreach and education for those who serve them as their healthcare providers. I don't know if others want to say anything about that. Anne, did you want to mention the call where we're going to be lasering in on promotion to providers?
Sure, yeah, you beat me to it. It was in what I'm planning to say, wasn't the thank you. But yeah, so as a follow-up to this call, we're planning to have a similar call later this summer where we really focus in on some of the outreach and the promotion directly to providers, recognizing kind of what Anna was talking about just a minute ago, and in general that it's not just the beneficiaries that need to know that the treatment's available with, however they have to jump through, however many hoops they have to jump through or not jump through. But also the providers need to know that coverage is available so they feel confident when they write a prescription and when they advise a patient to quit. So if you signed up for this webinar, you're going to get an invitation to our next one. So we would encourage you to sign up for that as well if you're interested in that, specifically those outreach efforts to providers.
And thanks, Grace, for that question. So DeRay Coughlin has a question. Does each state have an updated list of Medicaid-covered quit smoking treatment fact sheets and other materials to promote Medicaid coverage for tobacco treatments and to assist providers help qualifying beneficiaries to quit?
I can take that question.
That one?
Yeah, so while yes and no is the answer to that question. So the American Lung Association collects tobacco cessation coverage data, as Erica alluded to before, both of all of the 7 FDA-approved medications, all 3 forms of counseling, individual, group, and phone counseling, and then any barriers to access that treatment. So all of that is posted on our website, and you can get to that from lung.org/cessation coverage, and that's updated on a quarterly basis. So you can look at it, and then from there you can build your own fact sheet. And if you've got specific questions, my contact information is going to be on the next slide, which I'll show you guys in a minute. And please feel free to reach out, and I'm happy to work through that, and if you have any questions, answer them. But you should be able to get a rough idea of what your state covers from that website.
Thank you. So to end the webinar today, we've got about 7 minutes, and certainly to close out our very valuable time with 3 incredible examples of public health leadership. I was hoping that each of our panelists could leave us with one piece of advice for the most important first step for a state that is currently not focused on increasing utilization of covered cessation treatments in the Medicaid population to take. So Anna, I will turn it over to you for your final words of wisdom.
Okay, I guess, well, the main thing I would say is that, if you haven't started working on it yet, this is a group that, really is experiencing a lot of vulnerability and burden from this, behavior of smoking, and that, any time spent working towards helping them would be working towards lowering the overall burden of tobacco, in your state. So it's always a good group to consider working with. And I guess, the only other thing is, I know sometimes, when media kind of groups and communications groups get involved, they can get so excited about the promotion itself that you can sort of pull away from reminding yourself that, it's policy-based interventions through insurance, for instance, like this, that really help people to quit. And so, you want to keep your focus on the big picture, which is the policy piece. Don't get too excited about what colors and fonts and, 5 different versions of the same tagline are. Just, remember what is most going to matter to the person who wants to try to take their card in and just get, this service so that they can try and quit smoking. It's really about the policy. It's not so much about the communication, although there are, better and worse communications to do. That's what I would say.
Great. Thank you, Anna. And Amy and Vicki.
Hey, this is Vicki. I would just say getting the right people around the table from the beginning to help, clarify things and shape your language and help you, with that inside track and moving your proposals forward. And not only involving the right people at Medicaid, but stakeholders to help you in your promotion efforts, part of your network, like our tobacco control network and other stakeholders that work with this office, involving them and just having all hands on deck to, once you get clarification, to be able to move everything forward. And sometimes to even help you get that clarification, you'll need your stakeholders.
Amy, anything to add?
No, I think, as Vicki stated, as we move forward with Medicaid and developing those relationships, it helps us to refine what it is that we're asking, and using their language really helps to clarify what it is we're asking for.
Which means that you may have to sit at a few of their tables before you invite them to yours, right?
Absolutely.
Great. Well, I can't thank the 3 of you enough. At this point, I'm going to, and certainly a huge thanks to the great participants and your compelling questions. And so with just a few minutes left, I would love to turn it back over to Ann DiGiulio to close us out.
Thank you, Tamitha, and thank you to everybody who joined our call. We really appreciate you being on it and taking such a great interest in promoting the coverage and the benefits of tobacco cessation treatments. Thank you to all of you who asked questions. If your question didn't get answered, or if you didn't have a chance to answer it or ask it, please feel free to send me an email or give me a call. My number is on your screen right now, and as is my email address. I'd like to give a wonderful special thank you to our speakers, Anna, Vicki, and Amy, to all the states who we talked to in creating this document, and then to all of you. Again, if you have any questions, please feel free to reach out, and we will be sending you information on that upcoming webinar that we talked about later this summer about promotion directly to providers. Thanks again, everybody, for joining, and we hope to talk with you soon. Bye.
And this does conclude your teleconference for today. Thank you for your participation. You may disconnect at any time.